In Unit 2, we will be discussing restrictive lung diseases, the causes of each, the signs and symptoms, diagnostic studies to evaluate these patients, and appropriate treatment plans. This information will be useful when researching your pulmonary disease patient and writing your research project 1. Restrictive lung diseases, or RLDs, are the focus of lessons 6 through 8. The definition of restrictive lung disease is an abnormal reduction in pulmonary ventilation due to restriction of expansion by the chest wall or the lungs, or both. The pathogenesis of these diseases are the following. 1. Decreased compliance due to stiff, hard-to-expand lungs or increased resistance to lung expansion. 2. Decreased volumes including IRV, VT, ERV, and RV, and decreased capacities such as TLC, VC, and FRC. And lastly, 3. Increased work of breathing due to increased transpulmonary pressures. Diagnosis of restrictive diseases are made with patient history, such as exposure to toxins, patient assessment, chest x-rays, and PFTs. As we discuss each disease that falls into this category, we will address them individually. As a general rule, we will be looking at PFT and patient findings to identify cardinal presentations. There are 6 classic clinical signs for RLD, which include tachypnea due to decreased volumes, hypoxemia as ventilation perfusion mismatching becomes greater, decreased breath sounds with dry inspiratory crackles, decreased volumes and capacities on a PFT, and cardiopulmonary as hypoxemia progresses and right-sided heart failure becomes apparent. Treatments will be identified as either supportive for permanent restrictive lung conditions or corrective treatment if the patient's condition is reversible, such as chest tubes, or supportive until the patient's condition improves, such as mechanical ventilation. Supportive measures may include oxygen, antibiotics for secondary infection, CPAP, BiPAP, or mechanical ventilation, aerosol treatments, suctioning or CPT, and good nutritional support. Although aging is not a restrictive lung disease, it often ushers in decreasing compliance after the age of 20. Compliance generally decreases by 20% for the next 40 years, and maximum voluntary ventilation decreases by 30% between ages 30 to 70 as respiratory musculature diminishes and arthritic changes occur in the ribs. Elastic recoil in the lungs and alveolar surface area also decrease, reducing vital capacity by 25% in the same time frame. Of course, there is no way to prevent aging, but patients should be encouraged to aerobically exercise and strength train to preserve as much oxygen carrying capacity as possible, because the cardiovascular system also declines with age. Also, sleep apnea may increase in this population at a rate of 30 to 40%, so a sleep study may be an important diagnostic tool. The first group of restrictive lung diseases are interstitial lung diseases, such as pulmonary fibrosis and sarcoidosis. Idiopathic pulmonary fibrosis, or IPF, is characterized by inflammation in the alveoli, leading to scarring and fibrosis. It is chronic, irreversible, and usually lethal. The cause of IPF is unknown but may be both environmental, with cigarette smoking and exposure to wood and metal dust being the highest risk factors, and genetic. Diagnosis is usually made by reviewing patient history for exposures, high-resolution CT scans that show small nodular densities and dark fibrous tissue, and surgical lung biopsy. Patients may exhibit severe dyspnea and cough, pulmonary hypertension, cardiopulmonary, thick black sputum, barrel chest and weight loss, and have diminished or bronchial breath sounds above atelectic areas or rales and bronchi with bronchitis. PFTs will reveal decreased volumes and capacities, decreased DLCO and lung compliance, and increased respiratory rate. There is no standard treatment, but corticosteroids may reduce inflammation, and a new antifibrotic drug, pirfenidone, shows promise. Patients are encouraged to stop smoking, and support measures such as oxygen and good nutrition and treatment of infections are encouraged. Lung transplants may be the last-ditch effort, but show only a 50% survival rate after 5 years. Sarcoidosis is a multisystem disease characterized by non-caseating epithelioid granulomas and multiple organs and generally affects young adults. The distinct features that show up in the lungs include alveolitis, round or oval granulomas, and pulmonary fibrosis. Diagnosis is made with patient history and chest x-ray, showing bilateral hilar lymphadenopathy and diffuse infiltrates with interstitial reticulonodular patterns. Breath sounds usually have rales or occasional wheezing. PFTs will show a 20 to 30% decrease in volumes, capacities, flows, and DLCO. Treatments are usually not needed, but when given, steroid-sparing agents are the drug of choice. Corticosteroids may be used to suppress alveolitis and granuloma formation. Coal workers' pneumoconiosis is an RLD caused by long periods of exposure to coal dust, 10 to 12 years. It is characterized as either simple, with small opacities on chest x-rays less than 1 centimeter in size, or pulmonary massive fibrosis with one or more large opacities. PFTs will show decreased volumes and capacities in DLCO. Supportive treatments include cessation of exposure, good nutrition, adequate oxygenation and ventilation, and exercise training to preserve remaining lung function or lung transplantation in advanced disease. Silicosis is another RLD caused by occupational exposure. This one, however, is due to silica, usually found in quartz and rock, and is marked by small rounded opacities and nodules that enlarge over time, usually in the upper lung fields, diminished breath sounds and shortness of breath and cough, and decreased volumes and capacities on PFTs. Treatment is the same as coal workers' pneumoconiosis. Asbestosis is caused by asbestos exposure, which is common amongst miners, construction workers, shipbuilders, insulation workers, and pipe fitters. Signs and symptoms may not occur until 15 to 20 years after exposure and will cause alveolitis and plaques, and diagnoses are made by occupational history and chest x-ray, which shows irregular or linear opacities and loss of distinct heart and diaphragm borders silhouette sign. Patients will have fine crackles, clubbing of fingers, dyspnea, recurrent infections, pulmonary hypertension, cor pulmonale, and weight loss. Pleural diseases that fall into RLDs include atelectasis, ARDS, and pleural effusions. Atelectasis is incomplete expansion or loss of lung volume and is classified into 5 types. 1. Resorptive or obstructive, which is due to tumors, foreign bodies, or mucus plugs. 2. Passive, caused by pneumothorax or diaphragm dysfunction. 3. Adhesive, due to decreased surfactants secondary to smoke inhalation, ARDS, pulmonary embolus, acute radiation pneumonitis, and pneumonia. 4. Compressive, due to tumors pressing on the lung or pleural effusions and empyema. And 5. Cicatrization, due to decreased compliance due to fibrosis. All forms will show opacity on chest x-ray in both the AP and lateral views of a lobe or entire lung. With tension pneumothorax, mediastinal and tracheal shift will be apparent. Treatment includes treating the underlying cause, bronchoscopy to remove secretions, or airway expansion and clearance techniques such as incentive spirometry and deep breathing and coughing. ARDS, and ALI, acute lung injury, is inflammation leading to increased pulmonary vascular permeability and lung weight, and loss of aerated tissue due to trauma, aspiration, drugs, inhaled toxins, sepsis, burns, pancreatitis, fat emboli, and reactions to transfusions. There are 3 stages of ARDS, including the exudative phase, where the alveoli fill with neutrophilic infiltrates and protein-rich edema, proliferative stage, where chronic inflammation leads to inflammatory mediators and scarring, and lastly, the fibrotic stage, resulting in fibrosis. Diagnostic tests include ABGs, which will show PF ratios less than 300 for ALI and less than 200 for ARDS, chest x-rays with bilateral diffuse fluffy infiltrates, decreased breath sounds with possible wheezing, rales, and rhonchi, tachycardia, and PFTs consistent with RDL. Treatment is aimed at correcting the underlying cause and supporting the patient with mechanical ventilation with lung protective strategies, usually using tidal volumes of 4 to 8 milliliters per kilogram. PEEP may be employed with 5 to 15 centimeters of water to increase oxygenation and enhance alveolar recruitment. Prone positioning may also be employed, and fluid and electrolyte balance are of critical importance. Advanced techniques such as atriovenous hemofiltration, CAVH, or dialysis may also be employed. Pleural effusions are accumulations of fluid in the pleural space. They can be transudative due to increased hydrostatic pressures in the pleural capillaries, as commonly seen in congestive heart failure, or exudative due to increased permeability of the lungs, as seen in pneumonia and malignancies. Effusions are diagnosed by clinical history and exam, followed by chest x-ray and pleural fluid analysis. Further studies may include CT of the thorax, pleural biopsy, thoracentesis, thoracoscopy, or sometimes bronchoscopy. Patients may exhibit blunting of costophrenic angles and opacity in dependent regions on X-ray. bronchial breath sounds and agophony above the pleural effusion, sometimes a pleural rub if inflamed pleura is present. Treatment consists of treating the underlying cause in thoracentesis and chest tube drainage. Lastly, we'll look at the infectious cause of RLD, pneumonia. There are 4 types of pneumonia. 1, community-acquired, 2, hospital-acquired, 3, healthcare-associated, and 4, ventilator-associated, VAPS. Causative agents include streptococcus, which is the most common cause of community-acquired pneumonia, Legionella, Haemophilus influenza, which is common in COPD patients, Klebsiella, common in alcoholic and diabetic patients, Pseudomonas, which is most common cause of nosocomial infections, Staphylococcus, common in cystic fibrosis in COPD patients, Mycoplasma, viral pneumonia such as cytomegalovirus, varicella zoster and herpes simplex, and fungal pneumonia such as pneumocystis carinii or PCP, often seen in immune-compromised patients. Diagnostic tests include history and physical, and chest X-ray, which show lobar or diffuse consolidation or infiltrates, or cavities when necrotizing. Patients will have bronchial or absent breath sounds and dull to immediate percussion. Rales or rhonchi may also be heard. Droplet precautions may be required when treating these patients.